Here, particularly kinds of treatment that have been empirically shown to be effective. For instance, psychoanalysis is used, but we don't know whether or not it's effective. Empirically, we can't know it. Cognitive therapy, efficacy has been shown in many studies. Biological approach, mental diseases relate to brain functions first, and neurons and interneuronal relationship synapse is considered. Bunun şeysi yok mu? If we consider a more holistic approach, I'm sorry, the screen cannot be seen. The environment, I can't read, sorry. The effect of biology, emotion and physiology, environment, thought has to do with the way people think, something shaped in the childhood period. These are what we call schemes. Behaviors are an impact and a reaction to the environment, but they also end up affecting the environment. All of these cause the problem to emerge.
Normalde şuna yansıyan buraya çıkıyormuş çünkü.
And then there are biological factors in the etiology, hereditary factors, and biochemical effects, second personality effects, which mostly have to do with early childhood experiences, but also thought forms that persist, and third, environmental events. How does this work? Okay. Medication treatments are mostly active over the physiological pathway. It's not our topic today, but interpersonal therapy is effective over environmental events. Medication, again, to a certain extent, it has a direct impact on emotions. It may have an impact on the way, on how intensely the emotions are experienced. Thought, cognitive therapy has to do with thoughts, and behavioral therapy has to do with behavior. Why combined therapy? Now, if something is effective and something else is also effective, if we do all of that simultaneously, can we obtain more effects? That's how the thinking goes. But that's not always the case. In general, 1 + 1 does not equal 2. Maybe 1.5. It's not like they make an effect on top of one another. We never get a dramatic effect. So, in all studies, when you combine therapy and medication, you don't get fantastic results. This gentleman never puts on the microphone, so I never hear him. I'm sorry. There it is. I'm going to talk about this in my slides, but both treatments impact on similar points on the brain, so there are differences in only 1 or 2 places. Because of this, even if they have an additive effect, what they really do does not constitute very different results, even if the methods are similar. Drug and pharmacotherapy and psychotherapy, the interaction between those two. Medications have a placebo effect, which have to do with psychological factors. Again, medication can increase the impact of psychotherapy by alleviating frustration, increasing attention and concentration. Again, psychotherapy has a positive placebo effect. Psychotherapy may increase drug compliance. Psychotherapy, even though it's based on interaction and words, that also has biological effects. Now, what I see in drug trials is, in trials which compare drug and psychotherapy, they give drug to one group, and let's say they see them once a week. Those skills are given to them, the tests. I guess it takes half an hour to 45 minutes, even if it's only drug treatment. That's the period of time the doctor spends with the patient. On the other side, there is the psychotherapy. I think such comparisons are totally unfair, because the group which is receiving medication, they also have the placebo of psychotherapy, but the group receiving psychotherapy does not get the placebo of the drug. If both were done, it would be a more fair comparison. One group medication, the other group placebo plus psychotherapy. I think you're totally right. Every clinician who works in this field is aware that gaining the patient's trust, taking an interest in him, these are very, very determinant effects. I remember in studies outside of Turkey, we had two psychologists. One was very considerate, understanding, was all smiles. The fMRIs he took gave different results, nothing to do with the medication, but the other psychologist, his films gave different results because the patient's anxiety was elevated. And particularly if, let's say, if it's a competition research, if patient's compliance is very important, then this time, of course, then you behave very empathically to the patient. Well, we always have to be like that, but so therefore I think what you said may be applicable, because we call the patients as well in a research situation, and the patient likes this. These all have positive effect, I'm thinking. Sorry, no microphone. Sorry, the speaker is not speaking into a microphone. Yes. Now let's go over disorders one by one. Particularly when we come to anxiety disorders, the combination of therapy and drug, that may be a bit problematic. Now, this is a holistic model about depression that I like. There's a genetic propensity in some brains when negative life events come together with this, and this resistant phenotype emerges. This is a slide from Neuro. For instance, in trials performed on monkeys, in the infancy period, you separate the monkey from the mother. Negative life event, you have a more vulnerable phenotype, meaning it is a universal response against stress in humans and animals. Cortisol elevation. Cortisol elevation is an adaptive mechanism in the short term to cope with stress, but when it is prolonged, it plays a role in the etiology of depression. So this is done over the HPA axis. In case of stress, your cortisol gets elevated. In early phase negative life events, people who experience those things, cortisol hormone response against stress is higher and lasts longer. In more vulnerable people, in their adulthood, when they encounter trauma or negative event, the cortisol response against that stress is higher and lasts longer. Then other biological alterations come into play and depression emerges. So this is the explanation. For instance, in early life trauma monkeys exposed to early life trauma. In this trial, they give them paroxetine. After they give paroxetine, this cortisol hormone elevation response against stress becomes lower, becomes more blunt, and lasts shorter. Does antidepressant treat the vulnerability, underlying vulnerability? No. When you stop the antidepressant, that excessive response state re-emerges. Meaning, as long as antidepressant is used, that excessive response, that reactional HPA excess, the cortisol response is corrected. Would you like to say something about this? Our recent studies are always related to this. Probably HPA axis works over the amygdala, and the amygdala system is under serious control during the first years in normal people. In infancy, the system does not work very well, unfortunately. Plus, it has to do with conditioning as well, and it's related to memory as well. So all of those continue within the amygdala. In later years, the hippocampus takes it over. So cortisol elevates higher in early years. As cortisol elevates, the shape of the cortisol receptor changes. And even more interestingly, once this changes within the first year, it never corrects itself. And throughout life, the same sensitive cortisol receptors remain with the human being. And this has to do with the child-mother relationship within the first year of life. So we have to be careful about this. For instance, our assistants keep saying depressive mother, postpartum depression, or within the first 2-3 years of the baby. We say we're not only treating you, we say we don't want another depressive patient in the future. We're thinking of your child as well, we say to the mother. It's not like we want to scare anyone, but a child with a depressive mother, they become depressive in later life. Sorry, can't hear. Is this learned behavior or biological grounds? The needs of the child, staying away from pain and sorrow, getting the required physiological care, and I think it covers these things. For instance, was it Mel Bella? And in adolescents and children, when they talked about bipolarity there, the parents behaving warmly, warm interaction with parents is a positive event. Drug treatment, what does it do in the brain? What does cognitive therapy do in depressive patients? PET findings are compared here. One group is taking paroxetine, the other one is receiving cognitive therapy. Those to improve what kind of changes happen in the brain. So this is what the PET has looked for. Now, patients who improve with cognitive therapy, what is seen is in the frontal and parietal areas, there's less activity. The frontal area has to do with thought, with conscious thought. Hippocampus and dorsal midcingulate, there's increased activity there. You may think this is positive as well because an atrophy, a reduced activity is observed in hippocampus in times of depression. The common change in both therapies is the activity reduction in ventrolateral prefrontal cortex, which is a positive thing. Only paroxetine-specific inferior temporal hippocampus, brainstem, and cerebellum increased activity and reduced activity in the thalamus. The interpretation here is, of course, this interpretation is too simplistic, but antidepressants act from bottom up. First, subcortical structures, dorsal right locus ceruleus, hippocampus, hypothalamus. Then, the frontal cortex changes are secondary. Cognitive therapy is from top down. It first impacts on the cortex, and later on, indirectly, it has an impact on other centers. So in that sense, cognitive behavioral therapy, it changes the moods of the person. Vegetative, somatic signs, sleep, appetite, energy, and motivational signs improve later on, whereas an antidepressant, first of all, vegetative, somatic signs, motivational signs improve, and that hopelessness, that pessimism, that sense of desperation improve later. When we were assistants, we were taught this. Antidepressants cause suicide. Well, this is known. Antidepressant reinstates strength, energy, and pessimism is still continuing, so there may be suicide attempts at that period. It was classical information, but it keeps re-emerging in different formats these days. I think that data has to do with adolescent group, the group up to 24 years of age. There's increase in suicidal ideation, but they don't actually carry it out. There's not an epidemiological increase. If there's need for antidepressants, then we should not really we should really consider, but you should also consider the alternatives. Now, APA's depression-related recommendation is that mild and moderate depression by itself or together with drug treatment therapy can be used. If there's pronounced psychosocial challenges, interactive difficulties, and comorbid access to disorder, then in addition you may consider therapy. In moderate and severe depression, first of all, drug treatment is recommended. If the same conditions are present, then combination therapy is recommended. And psychotherapy, interpersonal and cognitive behavioral therapy. Panic disorder. There's controversy here. One group say panic disorder is totally psychological. It's individual specific. There's no biological reason etiologically, especially David Clark, Paul Kalslowski, English cognitive therapists champion this. David Barlow is American cognitive behavioral therapist. He says it's both biological and psychological factors that come into play. Psychologically, it's a hyperactive alarm system that is easily triggered. In the biological sense, that's what he says this is. Integrative theory, Jack Goldman, especially involved in panic disorders. He has an integrative theory. That theory says the following. Amygdala is a center of fear reflex. Projections from parabrachial plexus increase respiratory rate, and projections that come to the lateral nucleus of hypothalamus activate the sympathetic system. Locus ceruleus impacts on neuropinephrine release. Hypothalamus paraventricular nucleus, the impact on it is carried out by the adrenochromatoid release system, and periaqueductal gray matter projections is responsible for defensive behavior. All projections to the brain regulate the fear reflex, fear reaction. Again, by APA in panic disorder, cognitive behavioral therapy is recommended. What to go for, drug or therapy, depends on the situation, depends on the personal choice of the patient. What do you think? What is your opinion on these theories. Be my guest.
Bunu açmanıza gerek yok diyor.
Ha?
Bunu açmanıza gerek yok diyor.
Tabii dinleyen yok.
Now the symptom-based classification is not so correct, I think. Some disorders have psychological, some have physiological reasons. For example, schizophrenia is mainly due to biological reasons, but some psychotic events may be due to psychological reasons. Bipolar, if it's well defined, most of the time is biological. Panic disorder, 2/3 of panic disorder is psychological, 1/3 is biological. This is what I believe. Depression maybe half and half. But the biggest problem is from classification being based on findings. Fever. Fever is finding. If we make a classification based on fever, we can find tens of reasons. So if they ask you what the reason is, the reason of schizophrenia, or the reason of bipolar disorder, or the reason of panic disorder, you may ask which panic disorder, which bipolar. I believe that the reasons vary according to the person. Some people have agoraphobia, that type of panic disorder, and Freud defines it as unconscious behavior of attack or assaultive behavior, and that sometimes fits well. The problem with psychoanalysis is everything is regarded as psychological. That's the fault with psychoanalysis. Here's a study made by Barlow on psychoanalysis. This, I believe, and I'm sure, is quite complicated. Let me try to summarize it. Some receive placebo, some drugs, some CBT plus drugs, some CBT plus placebo, and the first group is CBT alone, cognitive behavioral treatment alone. Those who complete the treatment, 65%, therapy 84% combined, cognitive plus placebo 80%, and placebo is 38%. Looking at the 1 year follow-up, 85% of the cognitive therapy receivers are in good shape. Imipramine, 60% are in good shape. Combined, imipramine and CBT, 50% are in good shape. Placebo and CBT, 83% are in good shape. So in the combined therapy arm, it seems that there isn't a very good table. It may be due to the fact that the population is very limited. It's not seen in the placebo group, it's in the real drug group. They are just as good as the therapy receiving group. What we say here is that especially SSRIs desensitize the projections of fear network at the level of amygdala that lead to hypothalamus and the brainstem. Furthermore, effective psychological therapies are effective on the prefrontal cortex and hippocampus in reducing contextual fear and cognitive dissociations. This is what I use to explain panic disorders. Serotonin is misregarded as a happiness hormone, something that's good for people. Internists think that way as well. If you give a full dose SSRI to panic disorder patients, patient gets worse and says, I was about to die. Because serotonin increases anxiety. That's a neurotransmitter that increases serotonin. Once you give the medication, serotonin is increased, but in a controlled fashion, in a more conservative fashion, and over a period of 3-4 weeks, there is desensitization. Once you give the drug, you can explain to the patient, and you can modify the dose, so there won't be a big problem. The question cannot be heard.
Kognitif yanlış atıf. Dissociation herhalde. Güzel değil mi? Kognitif yanlış atıf.
Aa, ne? Ya
Çok
güzel,
hoş değil mi?
güzel, güzel. Ha, bütün salonlar sinek avlıyor.
Öyle mi?
Yani bizimki de en azı ama. Dur bakayım, neydi cognitive dissociation? Bilgisayar yanlış atıf.
20 milligrams of paroxetine, 10 milligrams of escitalopram can be given to the panic patient, but he would feel much worse because it would add on to his anxiety. You have to start at lower doses and then titrate up slowly. It's not high in the long term. It's due to the sensitivity of changes in the sensitivity of the receptor, because if it was due to serotonin increase, it should have taken place at day 1, but improvement takes place in 2-3 weeks. Reduction of the sensitivity of that receptor, yes. Serotonin is not anxiolytic. Is that right? There is a hand behind.
Tabii o keyif veriyor, anksiyete vermiyor ki. Anksiyete rahatsız edici bir duygu.
Gitmiş mi Elif?
Ha, o salona gitmedim. Ha yok Elif oradaydı hala, gördüm. İkisi yapıyorlar beraber. Ama bütün salonlarda çok az insan var ama rekor bizde.
Thank you for the contribution. Well, the way to look at it is looking at the neuron from raphe nucleus to the limbic system. In depression and in panic disorder, there is tetany. It may be due to the non-transposition of increasing of the serotonin and postsynaptic receptors 5-HT2A and 2C. These provoke anxiety. These receptors increase. So if you administer a high dose at the outset, you increase serotonin in all sites, and 2A and 2C transpose or transmit anxiety very quickly. Once you start in smaller doses, you don't only increase serotonin in the postsynaptic area, but also presynaptic area. 5-HTA receptors halt the neuron, and
Cardioversion.
as in the case of cardioversion, axon potentials start functioning, and so does serotonin release, regular serotonin release. That takes a couple of weeks. By the way, the amount of postsynaptic receptors are regulated again by that release of serotonin, the regular release of serotonin. Think of it this way: if you put a lead on the neuron, you can feel it's being activated, firing all the time. Frequency is very important there. But if you take a depressive mouse, you will get this sort of voice sound, because the axon potential stimulation does not really happen regularly. I can draw it for you if you like. And ECT works well because it stops all the neurons and activates them in such a way that they transmit axon potentials. Okay, coming now to OCD. What we focus on biologically is the prefrontal cortex, in charge of thinking. Then there's basal ganglia and caudate nucleus play a role, are culprits in OCD. In CBT, we see an increase in PET activity. Caudate nucleus is, well, let's put it this way. Basal ganglia are both regulating the motor and the cognition functions. For example, in Parkinson's, there's a problem with movement center. People fail to do consecutive movements. And in OCD, the problem at the caudate nucleus would be change of thought immediately. I mean, leaving one thought halfway and then going on, jumping to the other one. You cannot really shift gears, mentally speaking. Louis Baxter, and that's, by the way, a slide from UCLA, made a study on a group of people. He treats them with fluoxetine, and to the other group he gives behavioral therapy, and he tries to take note of the differences, the changes in the brain. Are they any different from one another, these both groups? It's unlike the case of depression. There is a homogeneous change. It can be through behavioral therapy or pharmacotherapy. In both cases, prefrontal cortex and caudate nucleus activities are reduced. This slide is not very clear. I know that, not very visible either, but that's just showing us how the activities are. Again, in APA's treatment guidelines, SSRIs and CBTs are the first line therapies in OCD. And it also says combined therapy is not required for all patients. It may be for some patients that cross a certain severity threshold. It's not very clear because psychotherapy plus pharmacotherapy would be too expensive, and if you're supposed to administer them together, there should be a point, there should be a justification for that, a rationale for that. Here's another study. One group is given clomipramine OCD patients, these are. And some are given exposure response prevention therapy, that's again cognitive behavioral therapy, CBT. Then there's combined therapy and placebo. There are 4 arms. This is 12-week therapy, and this is the response rate in completers. 86% in drug therapy, 48% in clomipramine, 79% in combined, and 10% in placebo. Placebo response is always the lowest in OCD. CBT seems to be very effective because it's 86%, as you see. But this study was conducted on over 800 patients. 25-30% of them refuse CBT in OCD, so that has got to be taken into account as we're interpreting these results. On top you see placebo, and then you see Vivax, OCD, this is the Vivax OCD scale, and moderate and severe, 25 to 27 points. Placebo, and then clomipramine, they start off with 27, go down to 18 points on the Vivax score. Combined therapy, and above it you see therapy alone. Here combined treatment seems to be better, but there isn't a statistical significance. Of course, the CBT was administered for 12 weeks. In the first 3 weeks, every day of the week, there have been 2-hour exposure sessions for a period of 5 days in a week, which means that 5 days in a week you see exposure for 2 hours plus 1 hour. Yes, they do it with the therapist, and then there's a homework, 1 or 2 hours of home assignment. I think it adds up to more than 50 hours of therapy time, CBT time, together with the assignments, homework assignments. Now coming to social phobia, genetics has a role to play. Candler has done many statistical work, and he says that 30% for social phobia and 39% in agoraphobia is attributed to genetics. Here there is a reduction in the dopaminergic activity, so hypodopaminergy is the problem here. The striatal dopamine reuptake intensivity is seen here. These are control groups, these are social phobics, and this is the difference in between. So there is a dopaminergic activity reduction, and it seems to be quite reasonable. For Gilles de la Tour disease, some patients show social phobia effects, or in some other patients due to hypodopaminergic situation. Or Bülent Ecevit had a tic and was given haloperidol. After that, he demonstrated social phobia-like responses. Here is group therapy and drug pharmacotherapy. We see reduction in amygdala, especially. This is what happens after group therapy, the amount. And this is with citalopram. And this is the difference between responders and non-responders. Responders have reduced activity in the amygdala, and we know that amygdala is in charge of fear response, fear reaction. But generalized social phobia is relevant here. When we talk about performance anxiety or limited social phobia, the activity is a bit different.
coming now to the biological diseases, psychotic disorders. This is the drugs-only group, relapse for drugs-only group, family therapy plus drugs, social skills training and drugs. We see a downward trend, and social training, family therapy, and drugs. All three administered together would pose the highest reduction of relapse. What I mean to say is that psychological elements play an important role in the most biological diseases. And again, biological treatment can be very useful in totally psychological cases. Sometimes you shouldn't just focus on the etiology to cure that problem. I mean, you cannot just cure a biological disease with biological means, and vice versa.
Please. In schizophrenia? In schizophrenia, up until now, nobody dared to perform such a trial. And if they have not published it. Can't hear what's being spoken. It's not being spoken into the microphone. Yes, of course, because in therapies, that's something that is being focused upon. Drug compliance. There are modules focusing on special drug compliance. There are techniques which ensure insight, like this is a disorder which requires drug use. In the UK, some groups are performing drug-free therapy, but I am not aware of anything that is published. And would it be so ethical to do something like that? That would be a question mark, because at the end of the day, there's a cognitive disorder, but that cognitive disorder is the product of a brain which has a propensity for biological disorder. So we can't hear. There's no microphone being passed around. But giving placebo in schizophrenia, I don't know. In drug research, that happens. Placebo to be better compared with a placebo. That's the first thing. But as Hakan has said, placebo has a bit of a positive effect. Let me give you an example. Recently, we've had a couple of patients, and I'm sure you have had too. The patient is at our hospital. The mother is accompanying. Same medications, same dosage, but mother is depressed because a young patient, a young son-daughter you have, a schizophrenic one, and the expressed emotions of the mother was too much. The mother went home, father came, and father was more cool type. Same medication, and within 1 week the child became a respondent from a non-respondent. I'm not really oriented to therapists, but we're trying to reduce stress factors in schizophrenia patients, and dopamine also comes down. So patient starts responding once again. This is not a systematic therapy maybe, but there are some behavioral corrections. And apart from that, let's give behavioral therapies to the patient and let's not give anything to the other side. I have not heard of such a controlled study. Maybe in the 60s, behaviorists may have carried out some trials on catatonic patients. You must have heard of those machines which give you what you want. So you place that by the patient, catatonic patient. If they look towards the machine, you give something they want. If they get up, then you give something else they want. These are reinforcement-based therapies, but in autistic children, they're reinforcement-based activities like increasing social activity, verbal expression, but they usually remain where they are. They can never go over a certain line. That's the information I am aware of. For instance, schizophrenia, there's an exacerbation. Let's hospitalize because it's happens even though they are compliant with their drugs. They hospitalize and, for instance, change the medication. You hospitalize them, and the following day, maybe separation from that home environment becomes sufficient to make the patient better. Then you give up on changing the medication. So things like Elisabeth has said may happen. Cognitive therapy perspective on schizophrenia is a stress diathesis model. There's like vulnerability on the part of the patient, and the more that vulnerability is, the more biological sensitivity, the less stress causes psychosis, and the less vulnerable they are, the more stressful psychosis they experience. Anyone in this room may experience psychosis if we apply adequate stress. So it kind of normalizes too. So to sum up, in major depression, combined treatment has positive impact. There's evidence. There's no such thing that says there's negative impact. In chronic or severe major depression, there's definitely positive impact. There's a CBASP, cognitive behavioral therapy type. In chronic depression, nefazodone has carried out a trial. Nefazodone by itself to one group and nefazodone plus CBASP on the other groups. There's almost twofold more positive effect obtained. Anxiety disorder, especially anxiolytics, do not seem to have a positive effect, but they do not have there are some negative effects. When we come to antidepressant treatment, they may have positive effect. Is there or not any negative effect? That's a question mark. And in psychosis, we know it has a positive effect, combined therapy, and there's no data which says it has negative impact. Now, about medication use, and then I'll finish up. Based on the cognitive theory, there is this event or situation. We perceive it, we understand it, we interpret it, as a result of which we develop reactions and emotions and behaviors. So, in medication use, the thing that determines the reaction, how he perceives it, how he attributes meaning to it, how he interprets it. In this sense, there are many negative beliefs related to drug use. These have to be changed first. What does the person expect from this medication? The handouts have this, therefore I'm skipping. There is a technique, well, not a technique, but small intervention that I use, particularly in schizophrenic patients. Does this have a side effect, they ask, for instance, infertility or any other side effect that may emerge later on down the line? Of course there are side effects. We have to say that up front. Here's the question I ask them. What is a substance which disrupts kidney and cardiac function, causes lung edema and brain death in the body when taken too much? I say it's water. So water. If water was a prescription medication, this would be among its side effects on the prospectus. For instance, butter. If butter were medication, on the prospectus it would say arteriosclerosis is a side effect. This is for patients who don't believe. What is water intoxication? Now, in order to increase compliance, there are interventions oriented towards patient-related factors, cognitive therapy, education about the disease, information about the benefits of treatment, factors relating to the clinician, training and informing on the side effects, and service, patient-centered service. And there are factors related to the social environment. Family education and support, because in many patients it's the family which is the most important thing. More access to the hospital and doctor, more things that can be done in the hospital about the drug. A simple drug regimen. The more simple a drug is, a drug that is used 8 times a day, there's less compliance for that drug than there is for a drug which is used once a day. The medication should have a few side effects, and of course the patient should be informed on how to administer it. In general, people don't like too small or too large medications. They have prejudices about injectable medications being more effective, bitter tasting ones being more effective. Drug incompliance should not be forgotten. Unless there is evidence to the contrary, we should assume that there is no drug compliance. Therapeutic collaboration is important. Also, you should not suffice with patients' self-reporting, and always obtain information from other sources. What is a barrier for drug use? These are problem-solving techniques, for alarms, people who remind a family member who has taken on that responsibility. If the physician does this, there's less of a problem. A family member may come to the meeting, and it's difficult for you to monitor your drug administration because of your condition. So let's take this burden off your shoulders and give it to your older brother, older sister, your mother, whatever, and they will give you your drugs whenever it's time. Sorry, can't hear. No microphone. Birisi mi geldi? If we have a mayor like that everywhere, then we can try with them as well. Side effect. Rather than the severity of the side effect, it's the problematic level that is created. There may be too many side effects, but it may be desirable. I had a schizophrenic patient. He was very happy. He said, because give me a medication and I will no longer feel a sexual urge. He no longer wanted to have any sexual desire. There may be side effects, but it's important on a personal basis. Again, the doctor should be interested in the outcome of the drug treatment. Then this increases compliance. Antipsychotics. This is compliance to antipsychotics. In schizophrenics, perception, thought, emotion organs are the brain. Around us, there are many things that we can perceive and become aware of. Perceiving all of them at the same time and attributing meaning to all of them at the same time will be most confusing. It'll be like there are various chairs in this room, there are voices from the outside, car sounds, the wall is a certain color, the position of the chairs, etc. There are many things. So perceiving all of these at the same time and trying to attribute meaning to all of these at the same time, then you can't focus on me or listen to me, and that will be confusing. In the brain, there's dopamine, the substance we call dopamine, like the radio television amplifier example. You want to listen to a certain station on the radio, so you tune into that station, or the amplifier exaggerates some sounds and suppresses others, and this is the substance called dopamine in the brain that does this. This medication will regulate the dopamine quantity in the brain. It will reduce it where it's too much, and it will increase it where there's too little of it. This may be the explanation you may give the patient. My opinion is that the term schizophrenia is, if it's excluded from classification, we will be very relaxed as physicians. Robin Murray had a recommendation, dopamine dysregulation syndrome. Let's call it that, he said, because a non-burden new disease name, a new disorder name that does not carry any burden connotations, patients will have an easier time accepting the medications, because the biggest reaction of many patients is, I'm not schizophrenic. Whether we accept it or not, schizophrenia has bad connotations. Recently, this student who killed 16 people, after that, on MTV, Emre Kongar and Mehmet Barlas were discussing this on TV, and they said, well, I'm sure there are mental diseases underlying this schizophrenia. There are many schizophrenics out on the streets, he said, and there are murderers among us. Schizophrenics can easily commit murder, he said. And he's supposed to be an intellectual and a very informed patient. Even if he can't think like that, schizophrenia equals potential murderer, then, imagine what other people will think. So, therefore, for instance, one medication has antipsychotic dopamine regulation effects when we say that to the patient, or without even using the word schizophrenia, but just by using the term psychosis. I have had no patients so far who refused or gave a strong reaction. But the minute you use the word schizophrenia, then things may go wrong. Yes. This is